Okay, so we are in week 3 and we are moving on to equine anesthesia. You should have received a study guide and the PowerPoint. The homework will be due on Friday at class time. All of that is spelled out on your email. So when we talk about the horse, and I've mentioned things here and there about horses, and I joke around that I feel like horses are just small cats. They do both act quite similar. And when I talk about the horse, I'm also going to get into breeds. Now, again, my experience is small animal. I do have experience with horses from Purdue. Um, and then I have friends that have worked in equine anesthesia. So I hope to bring some of that information. I don't claim to be an expert. But you guys are getting into large animal while we're talking about this. So once you're around horses, maybe some of this will make sense. And again, there is some notes underneath about horses. And one thing that is interesting, and it says it underneath, um, horses, although we think of them as this kind of a stoic, majestic creature, they tend to be flight animals. And when they feel afraid or they're fearful and they're in a strange environment, they want to flee. And we're talking like 1,200 pounds to 2,200 pounds of wanting to flee. So I feel like when you're around horses, you really have to be very on top of your game, paying attention, and learning to look at their cues. I mean, it's no different than when I'm, with a dog and a cat that I feel very comfortable with. I can look at their behavior and kind of sense, okay, he's nervous, he's giving me the eye, this one's rubbing on me, this one's purring. So, getting comfortable about what is horse behavior, but realize you have to have a plan. So depending on, they may come in the hospital nervous, they may come in normal, and then become fearful while they are there. So we just have to be ready for all scenarios. Um, Now, some challenges. When I talk about horse anesthesia, obviously their size is a challenge, but again, temperament makes them challenging because I'm okay restraining a 10-pound cat that's nervous. Am I comfortable restraining a 1,500-pound animal that is nervous? So this is how I think about it. One other big challenge about horses is that when we are going to recover a horse, it's much different than a dog or a cat. A dog, a cat, a cow, a pig, a lot of animals wake up nice and slow after anesthesia. Now, of course, you have some that are hyper excitable, but for the most part, most animals, when they're waking up, tend to wait till they're completely awake to try to stand. Horses are a completely different animal where once they feel like they are awake, all of a sudden they realize they're coming to, they have this innate desire to stand immediately. And then there are a lot of horses that try and stand way before they are ready. So I do talk about when we are recovering, sometimes we have to sedate them after anesthesia to keep them laying down. So there's some key things that I'm going to talk about, some key signs that you look for that tells you this horse is not ready to stand up. And if your horse starts doing this, I mean, most equine anesthesia techs, you kind of keep some extra drugs in your pocket because if you have a horse trying to get up, we may have to resedate them immediately. There are cases of horses, and this is the big scare or the nervousness that people have. If they try to stand too early, they can break a leg. And often if they break a leg, they are euthanized because it is very difficult to do a fracture repair on a horse because they want to stand. There's a lot of weight on the leg. It's very expensive and it tends to not work. So I know that sounds barbaric, but it is the truth. So we had a student do his externship in Shelbyville at that Centaur Equine Hospital. And the very first day of his externship, they had a pregnant mare and she colicked. So not only is she pregnant and she colicked, now they got the foal out, did the colic, they were recovering her, and she stood and broke her leg and she was euthanized because it was a very bad fracture. So I cannot stress upon you enough that we have to take great care and pay very close attention for their safety and also our safety. We were never allowed in the recovery stalls when I was at Purdue. Um, I have some videos that I'm going to send you guys that are really good videos about. Um, it shows a horse being anesthetized, and the recovery stall is completely padded, and it has windows, and usually people stand on the outside because really, unless you're extremely experienced technician, they usually don't want people inside a stall with a recovering horse because, again, I mean, people can get their head knocked in, teeth kicked in. It's very dangerous. Okay, so I've explained, and I'm going to get more into that further in the PowerPoint. So 350 kilograms. So again, that's, if you multiply that roughly by 2, we're talking 700 pounds to 2,000 pounds. When you see the Clydesdales, like when you guys saw them, when we were at the fair, they're upwards of 2,000, 2,200 pounds. A quarter horse might be middle range. And then you have kind of like your Arabians, which tend to be on the lighter side. But, we're getting down to ponies and foals and colts. So we range, and then even a miniature horse. So a lot of people own miniature horses, but they're usually less than 300 pounds. If you remember, I talked about the anesthesia machines and the breathing systems. Most adult veterinary machines can handle 300 pounds and under. So a miniature horse and a foal or a colt might take a small animal anesthesia machine if it's under 300 pounds. If it's over, they need to go on the large animal machine, which is the same as, again, the large animal and small animal machines are all the same parts. Everything is just much bigger on a large animal machine. So I'm talking about their temperament as a challenge, but let's talk about some of their unique anatomy and physiology. So remember, physiology is happening in the body. They are obligate nasal breathers. So one thing that makes it challenging is they have to be able to breathe through their nose. Now, when we intubate them for surgery, the tube is going to go in their trachea. But before surgery and after surgery, they are breathing through their nose. Now, a lot of horses get like a goopy nose. Sometimes they're in a stall with hay and they can have debris. If you're recovering a horse and a horse, if they get their head stuck in a pile of hay or like up against their stall and they obstruct their nasal cavity, they won't be able to breathe. So we always have to watch where their nasal cavity is. We always have to watch and make sure they have good airflow. One test of airflow through the nasal cavity, you could take, we'll say this was my hair tie, but if it was a cotton ball, you can take a cotton ball, pull some of the fibers, and hold it in front of their nose. Do you see them breathing? In small animals, when we want to check for nasal flow, we take a mirror. Say this was a mirror or glass slide. You can put a glass slide or a mirror under their nose. Do they fog the mirror or fog the glass slide? So if you were concerned, there are ways to test that. But definitely have to make sure they can breathe through their nose. One thing that is key also is they have a very large GI tract, very large amount of intestines. And what happens is a lot of times when a horse, most of the time horses for surgery are going to be put like laying on their side, or they're going to be put in VD. Even if they're laying on their side or VD, those intestines push on the diaphragm. When they put, now again, a horse, okay, let me back up even. If an animal is anesthetized, they are respiratory depressed. They're not breathing as deep. And then on top of that, I'm going to take these heavy intestines and push on their diaphragm and make it harder for them to breathe. So what happens is, quite often during anesthesia, we have a patient that develops atelectasis. And I've explained before, and I feel like no student should be able to go on to next term if they cannot tell me what atelectasis means. Atelectasis is areas of the lung that have collapsed alveoli. Now, horses have 5 lung lobes. There's going to be areas of the lungs that are going to exchange oxygen, but if the animal does not inflate their lungs enough, there's areas that are collapsed. The consequence to collapsed alveoli is you can retain CO2 and you potentially cannot oxygenate as well. So one thing that I want to put is you have to make sure that they are breathing, and most of these horses in the hospital are going to be put on a ventilator. Quite often, it's not like, and we don't wait for them to start having breathing problems, or we don't wait for a high CO2. Most horses, when they're put in the OR, are immediately put on a ventilator. We're not going to wait. We know this is going to occur. We're going to treat it right off the bat. So horses in the hospital are always put on a ventilator. Because, and I think there's a picture of the machine coming up, but when I talked about bag sizes in the machine lecture, small animal bags are sizes 1 through 5. Now you calculate the bag size for a horse the exact same way I told you for a dog and cat. You have 30 mils per pound and you round up. But in large animal, we have 2 bag sizes, a 15 liter and a 30 liter. So you don't have all those different sizes like in a dog. Those bags are huge. There's no way you're going to take your arms, unless you're Shira, and squeeze that bag. It's almost like a thigh master. You almost have to take your legs and your arms and squeeze together. For a breath here and there, that's fine, but a horse is going to need more than that. So to make it simple, put them right on a ventilator. Okay? What does a ventilator prevent? It prevents hypercarbia, which is too high of a CO2, and it's going to help reverse atelectasis. Now, animals with minor atelectasis are probably going to have a normal oxygenation status. So it's not like the minute they get atelectasis, they're SpO2. Remember SpO2 pulse oximeter? Put it on the tongue. That measures oxygen saturation. I don't normally see an effect of oxygen saturation right off the bat. But if atelectasis continues to get worse, it can affect your SpO2. And the treatment for that, the treatment for atelectasis, is ventilate your patient, potentially turn them down, because if you lighten them up, they breathe deeper. But a lot of times in this situation, you can't do that. So put them on a ventilator. The peri-anesthetic period, colic during the peri-anesthetic. Peri-anesthetic means during anesthesia, because there's pre-anesthetic, before, post-anesthetic recovery. Peri is during. So let's think about that. Like, I can't ask you guys to answer this question. Why would a horse be prone to colic during anesthesia? Well, I'm slowing everything down. I'm slowing down their metabolic processes. I'm depressing brain function. Intestinal motility is going to be affected, sometimes by the drugs we choose, atropine being one of them. Now, we don't use a lot of atropine in horses, but that can affect it. But also, they're just depressed. You're depressing the central nervous system. And anytime the gut, the GI tract slows down, gas can build up. They're not going to pass gas. It's going to build and cause pressure. And that's where colic comes from. Now, I want you guys to know, and if you're a horse person, most horse people that's a very scary word. You don't want to hear colic. Colic just means abdominal pain. So when a horse is colicking, or when a horse is colicky, we don't know the exact reason yet. It could be from a blockage, could be from a hay impaction, could be from extreme gas, lack of intestinal motility. Do you see what I'm saying? There's more than one reason. Colic is like an umbrella. It's like a broad term. And then the reason for the colic, we would have to get into. If it's anesthesia-related colic, it usually is colic that's coming because there is a change in gastric motility. So we have to be cautious for that. How do we know that they're colicking? Well, in an awake horse, they are going to be pacing and biting at their abdomen and such. But if I'm talking about a horse that's anesthetized, they could become tachycardic, the belly is swollen, but one thing that usually we listen for is gut sounds. If you listen for gut sounds, if a horse has motility, you're going to listen to their belly, their abdomen, and you're going to hear those gut sounds. And you should go over that in large animal because, or maybe you've already gone over it in large animal, because we listen to the quadrants, we listen for motility. Now, really this slide is big for a lot of reasons. And how long have I spent on this slide already? Neuropathy, neuro means nervous, pathy is disease or condition of, and myopathy, myo means muscle, pathy, disease or condition of. And that should say padding, not pad-eye, padding. So when you lay a horse down with sedation and they're laying on the ground or they're laying on an OR table, they have to be padded with something. Now I'm skipping ahead for a minute to say something. There are two ways to anesthetize a horse, okay? There's in-hospital anesthesia, which usually means you have an OR, a surgery table, a ventilator, an anesthesia machine, just how like we do surgery at school. You would have a whole OR set up for an in-hospital procedure. Sometimes people cannot get the horse to your clinic, and we do something called field anesthesia. It's also known as TIVA, T-I-V-A, total intravenous anesthesia, because if you're traveling to the farm, and again, I'm not a fan of Dr. Pohl. If you watch his show, he makes a lot of farm calls, and you can do a horse castration, laceration repair, teeth floating. You can do all that at the farm. You don't need to bring them into the hospital. Now, something like a colic, a joint scope, radiographs, you'd have to bring that horse to the hospital. But when you go in the field, you're not going to have your big fancy ECG monitor. You're not going to have an anesthesia machine, and you're not going to have a ventilator. Now, could you bring a portable oxygen tank? You should. I think most veterinary mobile businesses at minimum should have an oxygen source, but that's usually reserved for emergencies. It's not for anesthesia. It would be, my horse turned blue, he needs some oxygen. So when you hear me talk about the differences, I'm focusing mostly on stuff done in the hospital, but you can do farm calls and sedate and anesthetize a horse. But when they lay down, when a horse lays on the ground, there is a lot of weight. If you think about the downside of a horse, and then you have this whole upside, all of that weight is being pushed down on what we call the gravity-dependent limb. You hear me say gravity-dependent, it's the side that's touching gravity or the ground. So if I'm on my right side is gravity-dependent. But that means all of my left side is putting weight on my right side. Now, if this is for 15, 20, 30 minutes, probably not a big deal. Most people will tell you it's very bad for a horse to be laying down under anesthesia like that for more than an hour and a half. Most doctors are going to try to keep procedures under that. Colics can be very quick if they're uncomplicated. So I would say there are rare instances where surgery will definitely take more than an hour and a half, but you have to make sure that there's good padding if we think the surgery is going to take that long. Now, what is neuropathy? Neuropathy comes like, so if I have my brachial nerve, it's the nerve that controls the forelimb, okay? And then I have this big heavy leg laying on my brachial nerve. The weight of this limb laying in one spot for an hour and a half, it's going to put pressure on that nerve. There's a chance that that horse wakes up and it has damaged the nerve. So if the horse, has issues and they're dragging the limb, maybe they have neuropathy. Myopathy, think about, have you ever fallen asleep like with your arm in a weird position and it falls asleep? It's because you've cut off the blood supply to your arm and it feels tingly. Not too big a deal in people. If I'm a horse and my right side is laying on the table, all of those muscles are being compressed and they're potentially cutting off probably not all of the blood supply, but some of the blood supply. And then what happens is myopathy causes a condition called tying up, Tying. So another term used in horses is called, if someone says my horse tied up, it means what happens is their muscles actually, think about those muscle fibers tying up or tightening. Sometimes you see this, you can feel a horse and you feel kind of like squishy muscle, and then you feel this hardened area where the muscle gets really tight. That can be from a myopathy. And that just means that we didn't have adequate padding. The other thing that I will mention is we're going to talk about positioning. That's why we don't lay a limb. Like if I'm laying on my side, instead of me like this, I should position myself like this. So this upper limb isn't crossing and putting weight on the down limb. So I'm going to tell you, horse limbs always have to be positioned. So probably putting like a foam block in between the limbs. And there's pictures of all this in your book. So I hope people are doing the reading. But if I put a big wedge of foam, and it'll keep the legs separated so I don't cause that myopathy or neuropathy. And again, it's very key that we do this in horses. Okay. Okay, so let's talk about how we term the different levels of anesthesia that we perform in horses. Normally, you're going to still do your pre-anesthetic exam, just like we do in dogs and cats, formulate a plan based on their anesthetic status, blood work, physical exam, breed, history, procedure to be performed. Now, the procedure is going to tell us a lot. So I'm going to refer to something as light sedation, heavy sedation, or general anesthesia. Those are the 3 levels of anesthesia in a horse. If we do light sedation, that might be we want to do an exam. The horse needs a wound cleaned, teeth floating. Sometimes we, all of these procedures, hoof trimming, nasogastric intubation, or sometimes venipuncture, or when they get a catheter. So like when we do a pre-med in a dog, and then we put them on a table, we put in their catheter, it's easier to put in a catheter. It's very difficult to catheterize, and we use the jugular vein in horses. That's the vein that's used for the catheter. And usually we use a 14 gauge, 5-inch catheter. We're not talking about jugular catheters that are super long. These are just a longer version of an IV catheter we would use in a dog and a cat. So if I ask you what procedures can be done in a horse with light sedation, ultrasound, radiographs too. A lot of horse x-rays, they're going to need some level of sedation. These are all designed for the horse to be standing and to be fairly light but restrainable. If we move up to something that's called heavy sedation, it is also known as standing chemical restraint. So I'm using chemicals to restrain them, but I want to keep them standing. So heavy sedation is standing chemical restraint. Now, this is something we need, but a lot of times the sedation itself isn't enough. We will add a local block. So I just talked about epidurals, nerve blocks, joint blocks. You can do a block around, so say for example, a lot of horses in the pasture injure themselves on fencing. And if they lacerate the eye, you can do standing chemical restraint, which is heavy, and then they will block the nerves called a corneal nerve block, the corneal nerve, and it will numb the eye, and the doctor can do the procedure standing. A castration in a horse can be done with this heavy sedation. In horses, you might do something called an ovariectomy. So in a dog, we do an OVH, which is an ovariohysterectomy. You take the ovaries and the uterus. In a horse, we can do a surgery where they just remove the ovaries, the uterus remains intact, and they can do that as a standing procedure. Now, that horse will not come into heat and is not able to be bred, but they keep their uterus. So that's what an ovariectomy is versus an ovariohysterectomy. A mass removal. So these are things that we have to do under heavy. And let me, okay, I'm skipping ahead for just a second. Okay. I'm going to go back to those slides, but I wanted to fast forward to this picture. Here is a horse that is under standing chemical restraint. These are called stanchions or hocks or hobbles. So this horse was heavily sedated. You can see in the neck here, they placed an IV catheter. Now they have tubing, and we have an anesthetist standing here, and she can give boluses of drug to kind of keep the horse sedated. They've actually put this trash can here with a towel, because when a horse is standing sedated like this, their head gets very heavy and they need something to rest it on. So this enables them to get some relief. You can see their legs, this one's bent in the back. So a horse typically gets a very wide stance. A sawhorse stance, that's where the sawhorses, their legs go apart. They might start to kind of weave, but we don't want them falling. Now, this can be given IM, this can be given IV, but the dose that we pick is not designed to drop or lay the horse down. This is just heavy standing restraint. Now, what they're doing here, they've probably also added an epidural, and they have a flank incision, and the doctor's doing an ovariectomy. So this is an example of what it would look like to do a standing procedure. Okay, this isn't full OR, so not everybody's like capped and gowned and sterile drapes. They have a sterile drape over the area, and the doctor is probably wearing gloves, but this is a type of procedure that you might see standing. Okay, so when we select a protocol, kind of like what I've talked about in dogs and cats, we look at our database. What is the TPR? What is the history? What is the physical exam? What is the blood work? We assign a status, excellent, good, fair, poor, critical, based on all that data. Like a colic is probably going to be poor to critical, where an ovariectomy or a castration would probably be considered excellent. Once you look at the blood work, we assign a status, the doctor decides all that. What kind of a procedure are we doing? Again, can this be done in a field? Can this be done in a room like that picture? Or does it have to be in a sterile OR? We're going to do two types of anesthesias. I told you TIVA. The other thing we call that is field anesthesia, which means you're going to the farm where the horse is, and that's primarily going to be done with intravenous or IM agents. You're not going to have gas. You're not going to have oxygen. You're not going to have tubing. It's literally just going to be the horse, drugs, and a stall. And you take equipment out on a truck. Now, if we're going to do what's called in the hospital anesthesia, we can still do TIVA in the hospital, or you're going to use your injectable, and then we're going to intubate them and we're going to put them on gas. And that would be like in a sterile OR, like a colic surgery, abdominal surgery of another nature, surgery on a joint capsule, something that's an involved surgery. Most of the time, what I want you guys to know is field anesthesia or TIVA out in the field is only appropriate if the procedure is going to be less than 60 minutes. So duration of procedure is going to tell you a lot. If it's going to be longer than an hour and a half, that horse needs to really be on oxygen support, inhalation, IV fluids, monitoring equipment. So unless it's going to be fairly simple, if it's going to be in the field, it can be simple. If it's going to be beyond that, we need to be in the hospital. And those are just a couple of different examples. So you're going to choose your drugs, and then you're going to set up, usually someone pre-meds the horse. And I do everything that I would do like for a dog or a cat. I'm going to make sure that my machine is leak tested. All the tubing is hooked up. My IV fluids are ready. My monitor is on. I have anesthetic. I've checked the CO2 granules, and the machine is ready to go. The OR, I want to make sure that the OR, the padding is available. It's clean. Do I have my surgery equipment? Leak testing and checking your ventilator, making sure that the machine works before you put the animal on it. Now, warming equipment. We only really use heating pads and bear huggers if we're talking about like a miniature horse or a foal. An adult horse is usually not going to get that cold. We don't really have super big heating pads. So normally an adult horse is just on padding. But if you're going to have a smaller horse, you probably want to have a heating pad, some towels, make sure that's good. And then as always, anytime an animal is anesthetized, where is the crash cart? Where are the emergency drugs? And usually every OR has that in a good central location. And I will tell you, if we are doing anesthesia for something like a colic, or it's an animal that's in like fair to critical condition, a lot of times we will print out an emergency drug sheet. So I know those animals and those emergency drug dosages well before I start the procedure. And they are usually in a location where they can be easily found. Okay, once we have our equipment set up, now, I never usually have students memorize protocols, because when you get into whichever practice you're going to, you will be learning the protocols of that practice. So I usually stress individual drugs and their effects. But I will say in horses, for tranquilizers, we tend to use more acepromazine. Midazolam or Valium can be used, but usually when we use that, we're using it maybe as part of a ketamine protocol. As a sedative, midazolam, we need usually something stronger in horses. We use a lot of alpha-2 agonists. So xylazine, and two that I had not talked about, romifidine and detomidine. Not dexmedetomidine, but there's a drug called detomidine, and romifidine. And those are specifically large animal alpha-2 agonists. But they can use xylazine. Dexmedetomidine is used more in small animal. Detomidine or romifidine would be used in horses. And again, you can use opioids in horses, but typically they use butorphanol. Just because what I've said is the pure agonists like morphine, fentanyl, hydromorphone, horses are more sensitive. to those drugs, and they tend to react with more of a mania or a dysphoria. It's not like it makes them more sedate. It tends to bring out unwanted behaviors when we use pure agonists. So butorphanol is going to be a sedative. Now, anticholinergics, they are not routinely used as a pre-med because if you remember, anticholinergics, which are used usually to decrease saliva and increase the heart rate, they tend to slow down GI motility. Well, a horse is a species that is dependent on the GI motility for the health of their GI tract. So you want to do everything we can to keep it moving. We don't want to use anything that's going to slow it down. Let me say this, and please remember this. If you have an animal that goes into cardiac arrest and we need to use atropine, I'm not worried about gastrointestinal motility. I am worried about getting the animal back to life. So in an emergency, you would obviously use atropine, but I'm talking about it's not routinely used preemptively or just as a precaution. Atropine is typically used in an emergency if they absolutely need it. So that gives you an idea of some drugs that are used. And I'm going to talk about induction protocols coming up. So these are just kind of like our pre-med categories. And the same principles apply. You can either give the pre-meds IM or IV, but ideally you want to let pre-med set for at least 5 to 30 minutes. If it's IV, you want to at least give them 5 minutes. If you give it IM, ideally 30 minutes to 45 minutes is going to let those pre-meds kick in, and then we can move on to the rest of our protocol. Now, in this machine, you can see that, and the notes underneath it said, if you have a small horse, a pony, or a foal, if they're under around 300 pounds, you're going to use a small animal machine. If they're 300 pounds or greater, then you're going to need to use a large animal machine. And so if you look here, again, I'm going to point to this picture. You can see unidirectional valves. This is the rebreathing system, which is a circle system. It's just bigger tubing, a larger diameter. B is your soda lime. You got your flow meter, your vaporizer. What they have here, this black bag, and it looks like it has ridges, that is the ventilator. Large animal anesthesia machines have the ventilator built into the machine. Like at VCA, I had a ventilator in radiation. The ventilator sat on top of the machine, but it was a separate machine, and I hooked it up to my machine. A ventilator in large animal is part of the machine itself. So these are just different designs. And one thing and look how big this bag is. It's hard maybe to tell from this picture, but this is a 30-liter bag. The biggest you use in small animal is a 5-liter bag. So 15 to 30 liters are the two sizes that we use. So you can see the bag is here. Okay, so these are just showing you different arrangements of the machine. In the last picture, letter D, that is a ventilator. And if you look at the way, see how these, letter D, the black bag is like hanging? In this machine, the ventilator is at the bottom. These are what are called ascending and descending bellows. When the first two pictures, these are called ascending bellows because what happens is when it breathes for the animal, they ascend or go up. In this picture, these bellows are called descending because they push down. So ascending versus descending bellows, and a bellow is this black apparatus inside. That is what breathes for the animal. So, for example, when you guys, I say to bag the patient, you hold the pop-off down and you squeeze the bag. When an animal is on a ventilator, these bellows take the place of the breathing bag. You do not use a breathing bag when you have a ventilator because the anesthetic gas and oxygen are inside this black corrugated structure. So when the ventilator squeezes, it's going to compress. That's just like you giving a breath. Difference being when you have an animal on a ventilator is that is called CPPV. Continuous positive pressure ventilation. It means the ventilator is running continuously. We kind of take over breathing. When you have an animal on the ventilator, they are no longer breathing on their own. We are breathing for them. The reason we do it in small animal is if I have an animal sometimes with a really bad CO2, or if they have some lung disease and they're hard to bag for, they're severely respiratory depressed, I would put them on a ventilator. But all horses will go on a ventilator in an OR, and that is something called CPPV. When you bag the patient every 5 to 10 minutes in small animal, that's called IPPV, which is intermittent positive pressure ventilation. So IPPV can be once every 10 minutes, but CPPV, usually the ventilator is set somewhere to between 10, 14, 16 breaths a minute, and the machine does all the breathing for you. It makes my job easy because I'm not bagging for the patient. It's doing all the breathing for you. So it shows you all these, and there's some notes. You can see it's got some notes about the machines and the ventilators, but I've kind of explained everything for you. Okay, there are some special preparation considerations when we get a horse ready for anesthesia. So normally this animal has already been pre-medded. We usually bring them into a prep room, which is kind of like a big empty room, and we get the horse ready, kind of like our prep room in surgery at school. So the first thing is we do is we place an IV catheter, but the horse really needs to be sedated first. Put it in the jugular vein. Remember the size of catheter, it's not on the slide, 14 gauge, 5-inch IV catheter. The next thing you have to do is we have to wash their mouth out with a dose syringe. Sorry, I have to keep pausing it. So the reason when we rinse their mouth out is that even if horses are not typically fasted for the extended amount of time, and this is usually a doctor decision based on the horse and the procedure, but normally, sometimes they are withheld 12 to 24 hours. We withhold food prior to surgery. But also, sometimes when a horse is in a stall, they're going to find feed that falls in the stall and it's trapped in the bedding. And a lot of times they get straw and hay and feed stuck in their cheeks. Well, we don't want to intubate them and drag that down into the trachea. So let me just show you the picture real quick. So this is what's called a dose syringe. And we usually have a bucket of water, and all you do is suck up a bunch of that water, and someone holds them and you stick it in their mouth and you just squirt it. They're not swallowing and drinking the water. They kind of go like that, and then you'll see sometimes hay and oats and things kind of fall out. We usually do this 2 or 3 times to rinse this, and it says, again, this gets any feed material that gets trapped in their cheeks. The other thing that we have to do is most horses that come in have shoes put on their hoofs. And if you remember from anatomy, the horse hoof is concave, meaning it's kind of shallow on the inside. It's not flat. But when a horse steps in manure and mud and straw, that hoof is impacted with debris. So we'll always pick out the hooves. And sometimes we'll even put their hoof in like a bucket of soapy water with a big brush and scrub them, because again, they're going to drag any of that into the surgery. Now, if you're doing field anesthesia and they're at their farm, you're probably not going to pick out their hooves. But if we have a horse that's going under general anesthesia for like an abdominal procedure, and especially like a joint scope, we want those hoofs to be fairly clean before we take the horse into the OR. The other thing we do is we'll put the patient in an induction area or an adjacent tilt table. And let me get to a picture here. Well, I'm going to link a video to this, and it shows When you anesthetize a horse, we don't want them just flopping over. So we usually, when we give them the induction agent, normally you have a dog on a table and someone holds them. We put them up against a wall so that when they fall, people will kind of push the horse and the horse will go down. But there's also something called a gate, and we can put that against the horse, and that will actually allow the horse to fall readily. And some of this is going to make sense. I'm going to still lecture, but when I show that video, I'll kind of explain some of the things I was just talking about. Now, remember I said I would usually give light sedatives if we were going to go on to induction and general anesthesia. If you only want to do a procedure with sedation, this is when we use the heavy sedation or standing chemical restraint. And some people will usually call it an extension of sedation. How you achieve this is different between different doctors and preferences, but what we would do with this is sometimes the horse is given a light pre-med, and then sometimes the horse is given something IV just to the point where it starts to fall asleep, and then we stop. So usually you have to put the patient in some kind of stocks with like cross ties so that it doesn't slip out the front or the back. And you do this when you don't want to do general anesthesia. Eye lacerations, ovariectomy, laparoscope, all those kinds of procedures that I already mentioned in the other slide. How do we know that we've achieved the right level of sedation? This is going to tell you right here, and this is important for the test and what I want you to know. If a horse has achieved chemical restraint, they're usually standing, but the lip starts to droop. They tend to not try to move or try to leave. But what you're going to notice is a horse is going to be wide leg stance. So they're going to start to kind of and they may even start to weave, and they start to care less about what's around them. Head and neck usually are lower. If you think about horses in a pasture or a horse that's awake, usually their head is up and they're very much looking around. They're flight animals. They're always on guard. They're always nervous. So if I have a horse that's head is lower than its body and it's a wide stance, then I know he's in an appropriate chemical restraint. He's not caring about things that are around him. Now, I always go slow, and this is my biggest pet peeve. When people are around sedated animals and they're extremely loud, making banging noises, when they are sedated, they are still sound sensitive. Even though they look asleep, we don't want to do anything very quick around them. We still want to be slow. We want to be cautiously quiet. Don't bang metal lids. And, some people close gates really loud. Just be very careful. The other thing to notice about this is the patient can get additional drug. In this picture, okay, this anesthetist has a line, and what you can't see is that she's probably holding a syringe, and she's watching the horse and she's watching the doctor. She can be giving little boluses of IV sedation if the horse, say the horse starts to lift its head and the horse starts to stand up. She can give a little drug and it can go back to sleep without falling down. And but you can see this horse is protected in these gates, so it can't get out. We've got other people there. So the other thing that you don't see on this picture, a lot of times will put cotton in their ears, and usually we leave the halter on. If the halter's on, a lot of people will take a surgical towel or a long towel, and they put it over their eyes and they tuck it into the halter. So kind of like an eye mask. Because if the room is dark or the horse perceives it's dark, sedation is more effective. So I've sometimes even been restraining a dog and they're waking up or they're going to sleep, and I put my hand over their eyes, because if I can make the environment darker, it's just going to enhance sedation and enhance them going to sleep. Okay. Let me talk about induction and then we will show the video. Okay. The goal of induction, when you hear the word induction, is we want to basically intubate them and get them onto gas. We want to put them in an unconscious state. So when we do this in a horse, we have to do this very quickly, because what we do not want, you do not want to see stage 2 or excitement in a horse. So normally, remember when I've told you, like, you give propofol to effect. You give half your syringe weight, half of that weight, half. Normally when we do induction in horses, we do what's called a rapid bolus injection. So normally they will calculate drugs and they will give it as one steady push, all of it. Because again, we want to get them through to stage 3, plane 1 extremely quickly. We don't want to get in that excitement phase. So what you want to do is you want to get them from standing to lateral without injuring themselves or you. So again, if I ask you what is the induction technique in a horse, it's a rapid bolus injection. You do not give it to effect. Now there is one drug, and I mentioned this last term when I talked about drugs. I talked about guaifenesin. Guaifenesin is a muscle relaxant that we add to induction drugs. That drug you drip into effect. But like say the ketamine, xylazine, butorphanol, you would give all as one rapid shot. And then you could always drip in guaifenesin to effect. But remember, guaifenesin is not an anesthetic. Guaifenesin is a muscle relaxant, and it's used to just enhance relaxation. So some drugs that we give, ketamine can be used by itself, but a lot of times we do ket-val. A lot of times we do ketamine, xylazine. Propofol can be used in little horses, like if you have a small horse or you have a foal. But propofol in adult horse, you would have to use quite a bit and it would get expensive. So, and propofol doesn't last long. One thing you want in a horse is you want drugs that don't metabolize very quickly, because we want to keep them asleep so they do not injure themselves. So, most commonly, ketamine protocols are used in horses. Ketamine and an alpha-2. We don't usually use alfaxin. Hang on one second. Okay, I'm going to stop this video here, and then I'm going to record the second video, and I'm going to show a video of anesthetic induction first. So we're going to stop this video at induction, and let me know if you have any questions.